Welcome back inside the Now Morning Show. Now, as we've been paying attention to the COVID numbers and we see cases rising, we see unfortunately deaths rising as well. We're going to check in this morning with the Chief Operating Officer at the North Central Regional Health Authority to find out a little bit more about how they are prepping the Emergency Operations Center. Good morning to you, Mr. Davlin Thomas.
Hi, good morning, good morning. I'm getting some feedback with music though. How are you doing?
I'm all right. How are you doing? I imagine you have lots of sleepless nights these days.
Oh, for 2 years.
Yeah.
It's been an interesting 2 years.
Well, tell me about the preparations coming along at the Emergency Operations Center.
All right, I could give you a sense too of what has been taking place over the 2 years. At the initial stage of the virus approaching Trinidad and Tobago, we would have had to prepare Hoover Hospital, Arima General Hospital, segregate the biohazardous sides from the normal operational cold zones. So it's hot zones, cold zones, warm zones, and so on. Engage in ensuring that we ramp up the general activity in terms of the PPEs, ensuring that people have their protective equipment and so on to go in. So a lot of that is ongoing, and we have what we call a PHO, which is a public health observatory. That observatory would give us not just information about the past, but it would project the future for us. They've been spot on pretty much. So we were able to escalate, for example, our oxygen supplies generally, our consumables, reagents, calibrators, controls. Those are things used for testing and engaging patients to match the projections. And so that basically it was a matter of, in the past, whenever we got to the places that we would have imagined, we really started to roll out the plan. The difference between that and now is that we're in what we call an EOC mode or an IRT mode. EOC as an Emergency Operations Center that has been activated. The IRT, which is our incident response team, we were trained. A lot of the multidisciplinary teams at the North Central Regional Health Authority would have been trained by Falk International. Those are the persons who train like for example, out of the oil sector in emergency response. So we basically were training for that, and in particular, coincidentally, we've been training for our emergency response for highly infectious diseases. We did simulations just before COVID-19 broke out, when we were still calling it something else.
Now, Mr. Thomas, I imagine that all of these simulations and all these trainings, they would have prepared the staff to be able to deal with the pandemic. But I don't know that anybody would have expected it to still be going on almost 2 years later. So is there, we've been seeing lots of reports of burnout, we've been seeing lots of reports of even shortages with the projections that you mentioned just now. Did you guys project that it would last so long, that we would see so much more cases now, so much more deaths now? Was that all part of the projection as well?
Well, the emergency operations projections are 0 to 2 hours, 2 to 12 hours, and beyond 12 hours. So, for example, if you have a disaster out there in the oil sector, sometimes it does go out for 2-3 days. So the training did include that preparation. So we would not have had stockouts. And as I said, what kept us in terms of in terms of ensuring that we didn't have those stockouts would have been, and other kinds of anomalies, was that we were using projections consistently. So every week we get projections on what the next month is going to look like. And of course, sometimes that changes based on exponential changes in the environment. Because as it's a complex adaptive system. The issue for us though is that we've activated the IRT. That really now means that we have 3 tiers. One is a gray tier, which is basically a tier that says the hospital is full to its inherent capacity, meaning that if you consider like the variables of the staffing, the equipment, the room, the space that you have, then you're basically full. That's the gray tier. We have a blue tier that has different shades of blue. It started as just a blue tier, but basically we started to realize as we engage the projections and reconcile the projections with the reality that there were shades inside of that blue that we had to contend with. Blue is when we started to make novel changes in the way we do things to facilitate beyond 100% capacity. As you know, we are beyond 100% capacity currently. So we've made some novel changes in the way that we do things. Up to today, we're making some additional novel changes in the way that we structure so for example, the hospital would have been built one way. We realized recently that the recovery areas, which have all the, for example, all the resources, the oxygen, the piped oxygen and so on, have a different kind of spatial configuration that will facilitate additional patients to be monitored simultaneously. So for example, one of the things that we would have done in this deep blue area would have been or dark blue area would have been to do central monitoring for our ICU patients. Normally that would take millions of dollars. But what happened was that we were aware of switching technologies for using television sets. So we centralized our monitoring. So we have, for example, a room with 30 monitors that basically switch. So it means that we could see 60 patients simultaneously in terms of their monitoring. And you know, when you look on a television, so you see that beep, 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 it tells you how someone is going. We could do centralized monitoring. So the engagement based on the planning would have facilitated prior to us getting into that dark blue area, that if we do get into that dark blue area, what we need to do, and by dark blue again, it means that we're providing novel ways of adapting to engage over 100% and over 100% capacity. So basically, we've centralized that monitoring. So we now have a large room, if you imagine, a large room with television sets and monitors. And on those monitors, we could look at each patient. So you don't have to, so a doctor doesn't have to go in all the time to see how to look at a monitor of a patient.
Mr. Thomas, one of the things that that has been coming to the fore recently, I saw it, and I believe yesterday's papers, was the nurses and the general medical staff complaining about yes, they have to monitor patients, and you put a fantastic new technology in place to be able to do so. But how has the human resource been able to adjust it in terms of, retraining to be able to monitor the same way that they would in person? Because I imagine it's a different sort of monitoring that happens.
Well, no, doctors and nurses, etc., particularly clinicians, need to be able to look at the monitors. What we've done is redistribution of where the technology happens, as opposed to changing the technology itself. So we've done not adaptation, but what we call exaptation. We've used technologies that are used for other things normally and exapted that technology to use it for new purposes. So for example, in the past, the doctor would have had to go bedside to look at the screen. Now we've centralized all screens so that you don't have to go bedside to do that as yet. When we go bedside, it is to engage in care and so on. And so that, because remember, we have hot and cold zones. Now, the way COVID-19 operates is that once you leave a vulnerability, it's as if you have Murphy's Law on steroids.
Yeah.
And which is one of the things that we clear that the population needs to understand over and over. If you go to a vet, you ramp up the possibility of COVID-19 finding its way home with you and devastating home, particularly the unvaccinated. you know. But basically, though, I mean, we the team of the staff that we have, I mean, they've been going for 2 years. And now it's escalated, so it's not no longer just the duration, it's the escalation. You know, recently the numbers are higher, etc. In particular, in the um, ADs and in the ICUs. AD meaning the emergency department. So you could imagine the tension that is taking place in terms of our own resilience and but we are building what Taleb calls that some anti-fragility in the system, based on the fact that we have operating in the system the psychiatric department, psychologists, social workers, and so on, who are committed directly to engaging staff in detox sessions, etc. So that has been going for a while. So we've been building anti-fragility in the system and some resilience in the system for quite some time. But that doesn't mean that people are not tired, you know.
Of course.
We're in an engagement where people have much more to do than ever conceived and you've seen it in other countries, that a nurse, a doctor, an administrator, etc. Myself as the chief executive officer, I mean, where it's more engaging beyond anything that you could imagine, you know. So it's more than a 20, it's a 36-hour job. We have to, I mean, they have to, nurses, doctors, etc., have to etch that time out of the 24, a few more hours out of the 24.
Yeah, and I imagine it's not getting any easier as time goes by and they're being more and more exhausted. So we want to send out all of our best wishes to definitely all the medical staff, all the frontline workers. And I want to thank you so much for joining us this morning to share with us.
And just to mention the cleaners, the medical records, people tend to forget too as well, nurses, doctors, medical records, cleaners, wards, maids, etc. Remember, these people are at the front line, they're standing at the gate between life and death for a lot of people. You know, standing at the gate to ensure that virus doesn't leak out further into the community. And, you know, I mean, we have to cherish them and applaud them.
Certainly. Thank you so much for joining us, Mr. Thomas.
Thank you.
And all the best going forward.
Okay.